perimetry, which is very much required. Dr. Venkatesh, please.
Thank you, madam, and I sincerely thanks AIOS for getting all the innovators into the platform. The need of the day. I think even at crisis, people have to think out of the box. So this is again a good opportunity to showcase some of the innovations which has been happening across the country. So I have no financial interest. No, I supported a team to develop it, and now it's a product of a startup. So we all know standard automated perimetry is gold standard because it's not only going to diagnose glaucoma, we are going to treat glaucoma and also monitor progression. So it plays a vital role in every part of glaucoma management. And the problem with the HFA is you need to do multiple times. There is a lot of factors related to either patient being cooperative and also the reliability of fields. And we also need to closely follow some of these patients. And this has to be done in somewhere the facility is available. It's been quite bothering to us. If you take any innovation, I think this is the process. So you know the problem, then you get an idea, you design around it, and you do multiple prototypes. Finally, you come up with a product. So we all know the problem in HFA, it's bulky, it's non-portable. There's a lot of maintenance involved. Every time you need to get the company to fix it, you need trained staff to facilitate, to do how the patient do. And also it's time consuming. I always thought something like this. You have to, it's impossible to carry this field, even to change from one place to another place. And many of the times I was disturbed by seeing some of my patients at least, kind of sleep off during the fields. And then you go around and check their report, it's totally unreliable. So you have to keep all this in mind, and that's where the problem struck. And we wanted something to be done in outreach, which can be done at home if possible. So we want to do something which can be easy and comfortable. So that's where this thought process of virtual reality came. And that's when I met a very brilliant boy from VIT, Vellore Institute of Technology, who was a first-year ECE graduate. He came as a patient. He was a glaucoma suspect because of his myopia. He did, and then I told him, "No, what will you do to make the field simple?" He said, "I got an idea." So then he came back with his virtual reality idea, and then we both closely worked from December 2015 across a couple of years to come up with the first prototype, which was again a mobile-based unit. And then we came up with a brilliant idea of using two mobile phones to track what is happening in the visual fields inside. So the program was on a mobile field. And then we had an opportunity to showcase to a lot of doctors to see in AIOS to get their feedback. And then it became a standalone unit. After that, the mobile was gone. And there was a computer inside the virtual reality which could do the visual fields. And we did a clinical trial in 2018, and we also published in 2019. And now the supra-threshold visual field analyzer is available as a commercial product. And the company is now a startup company, which is already patented, and also most of the paperwork is done. So we call it a C3FA. Why C3FA? It's kind of compact, it's lightweight, easy, portable. You can do multiple patients seamlessly. You can conveniently use in outreach activities or in vision centers or in satellite clinics. And why comfortable? You don't have to wear an eye patch. You can automatically shut one eye. You can sit in any posture. You can lie down and also do fields. And also there's chance for fatigue because the time taken is very less. We are still working on publishing the cost effectiveness paper, but it's low. It's considerably low cost when compared to the HFA. And also teleophthalmology, which is the need of the day, is also possible in a CFA. If you see the differences between these two, minimal, it may take 15 minutes for an HFA, but for a CFA, it's something which is less than 5 minutes. Its positioning is kind of flexible. Even the patient can lie down and do. It's kind of handy, it's definitely portable. The cost comparison you can see on the screen. And if you take another important point, do you have to give a refractive correction? It's not required. Up to a certain diopters, plus or minus 5, it's not required. Beyond that, you may have to give lenses which can be put into the VR itself. And And again, it's not required. You can self-administer and the patients can do comfortably. And once they do a couple of times, they get very easy to do it. And if you see any distraction, so this is one thing which I was a little concerned when I was using the tablet-based perimetry. There were a lot of distractions externally, but VR didn't have any distractions, and there is no need for an eye patch. So you see some of those reports which compared to the HFA with a lot of clinical trials, and we also tried to validate. I'm just going to briefly tell you.
Now it's come back again.
Madam? Madam, is there an issue?
No, you continue. Please, I think that is Dr. Chandrama. Dr. Chandrama, please mute yourself.
Okay, right. So we did a lot of work initially to begin with, and then we did a formal trial, and we included patients which normally have glaucoma more than 70 below, more than 40 and below 70 years, best corrected vision of better than 6:1, any type of glaucoma, and the field should be also reliable. And we also had a normal age match control in our study. And then we excluded any other neurological or any other pathology like diabetic retinopathy, vein occlusions, and also these suspects were actually not excluded in the study. The two groups, both the glaucoma and controls, we did randomization, and then we did HFA first or CFA first, followed by the next investigation. And we also did OCT and fundus photo on all these patients. We also did a questionnaire to see how comfortable they are in using the visual fields between the two. And two masked glaucoma consultants finally made the diagnosis on looking at these reports and also looking at OCT and visual fundus photos. And then the data analysis was done. It wasn't very favorable, I would say. For early glaucomas, it wasn't very sensitive. But for more moderate to advanced glaucomas, if you see the area under ROC curve was not that brilliant, but it was good to a certain extent that it was able to catch up moderate to advanced glaucomas. The number of points missed on the CFA correlated reasonably well with the mean deviation, but less strongly with the pattern standard deviation. So I don't want to go into the discussion of this, but we found that the robust area under ROC curve for moderate to advanced glaucoma, but the sensitivity to diagnose mild and early glaucoma was not that great with the CFA. So we know that it's a kind of an initial step. We need to work over it. But the other interesting things when we did the questionnaire survey, we found that people were very happy to do the CFA. The time was less. They were more comfortable. And if they said, if they want to do it at home, 60% said they would buy and even do it at home in the future. So the main advantage is something like this. In your clinical setting, you can do like this. If the patient is lying down, you can do like this. So neurologists and neuro-ophthalmologists are loving it now. So after they remove a pituitary or some other stroke, before the patients can recover and come and sit in front of a HFA, they can do a CFA comfortably and see how it improves. So we had a lot of media and also attention. Our Honorable Lieutenant Governor, you all know Dr. Kiran Bedi, had a youth engagement program. We had a special invitation to the Innovator Sandal, who is next to me. And then we just want to highlight that this is one particular technology which is really useful in this pandemic, because you are worried about how to clean an HFA or an octopus, but this can be UV decontaminated. We are using it now, and we are also working on the next steps of it. Now we have the threshold versions and the fast threshold versions, which are similar to CETA. We are yet to publish it. We are doing data analysis now, but the study is completed. And we know that the sensitivity and specificity is much better than the previous versions now. And we also have a big grant, almost a 50 lakh grant from DST to take this again to the next level, because they saw how good it is and how it really helps to change diagnose glaucoma and treat. Thank you.
Thank you so much, Dr. Venkatesh. I think it's going to be really useful, especially for mass screening and especially in the COVID era. And that's a great